I'd like to acknowledge the local custodians of the land in which we meet this evening and honour elders past, present and emerging. Good evening and welcome to Asthma in Spring, Allergies and Thunderstorms. I'm Mel Wilkinson from the Hunter New England Central Coast Primary Health Network and the education team. I'll just go through some housekeeping. We will have a survey tonight, so please have a device ready to scan the QR code. Your feedback's really important to us and the National Asthma Council, who are in conjunction with this evening to present this workshop. Also, please remain on mute. If you have any questions, please utilise the chat box and we'll endeavour to get those to those in question time. There will be a time in the middle of the session and at the end of the session as well to answer those questions. If you are a GP and you haven't already submitted your RACGP points, if you could please send them to me via email, mWilkinson@hnaccphn.com.au. This will be live and will be on our website, but for 1 week only. So if you want to access that, you've got a week to do so. I'll now introduce Elle Williamson. She's an asthma and respiratory educator and a senior clinical consultant with the National Asthma Council. Over to you, Narelle. Thank you.
Thanks, Mel. Hi, everyone. I hope you're all safe and well up there in New South Wales. I was just saying to Mel, it's quite different for Melbourne to be the happy state and no cases, but we're thinking of you all up there and we definitely know what it's like. As Mel said, this is Asthma in Spring, Allergies and Thunderstorms. This webinar was written last year, around this time last year actually, and it's a great time for you all to be listening to this one because patients generally need to start medication not too far away from now, so it's really good timing to be listening to this in July. Mel's done the acknowledgement to country. So our learning objectives tonight are to describe the association between allergic rhinitis and asthma. We're also going to summarise the treatment guidelines for allergic rhinitis. We will describe those people who are at greater risk of thunderstorm asthma and the guidelines of management for those people. And we'll summarise the importance of written asthma action plans and asthma first aid in thunderstorm asthma season. Just quickly, these are a couple of websites. This is the Australian Asthma Handbook website you may have seen before. And the latest version is 2.1, which was released in September last year. And it provides best practice, evidence-based guidance translated into practical advice for primary health care professionals. So I really encourage you to go and have a look around. It's very easy to use the search function there. Anything to do with asthma, COPD, thunderstorm asthma, it's all in there. Then this is just the National Asthma Council website. If you wish to order any resources, you can do so online and then we'll send them out to you. We are in the office 2 days a week at the moment. So that's that website. All right, let's start with allergic rhinitis and a few facts. So approximately 15% of Australians do suffer from allergic rhinitis, which is also known as hay fever. So 11% of people in Australia have asthma. So 15% is, relatively speaking, quite a large number with allergic rhinitis. Allergic rhinitis is often underdiagnosed, undertreated and suboptimally self-treated. It's most common in those between 15 to 54 years, and it's an independent risk factor for developing asthma in children and adults. So the presence of allergic rhinitis is associated with worsening asthma control in both adults and children. Most people with allergic rhinitis are sensitised to multiple allergens, for example, both pollens and house dust. So symptoms can be present all throughout the year. The most common allergens are house dust mite, pollens from grasses, trees or weeds, animal dander and mould spores. And both rhinitis and asthma can be triggered by the same factors, whether it's allergic, for example, the house dust mite, pet allergens, pollens or cockroaches, or non-specific, for example, cold air, strong odours, environmental tobacco smoke. Asthma and allergic rhinitis is sometimes referred to as United Airways disease, as we know, asthma is an inflammatory condition of the small lower airways in the lungs, and allergic rhinitis is inflammation of the epithelial lining of the upper airway. So they're coexistent conditions. 50 to 80% of patients with asthma also have allergic rhinitis, and 20 to 30% of those patients with allergic rhinitis also have asthma. And some patients can mistake symptoms of allergic rhinitis for asthma and vice versa. Allergic rhinitis is sometimes more easily recognisable only after asthma diagnosis has been established. And it's obviously important to treat both conditions. In looking at assessing allergic rhinitis, we assess common symptoms, and they could be local symptoms such as nasal discharge, congestion or itch, regional symptoms such as effects on ears, eyes, voice, throat, including constant throat clearing, and it could include cough from a postnasal drip. And assessment may also indicate common symptoms such as systemic symptoms like sleep disturbance and lethargy. The frequency of symptoms can be seasonal or perennial. Seasonal is usually in spring or summer and often triggered by pollens from the grasses, the trees and the weeds. And perennial is, of course, non-seasonal or year-round, often triggered by indoor allergens such as dust mite and the moulds in the animal danders. And the impact of symptoms: if a patient has mild allergic rhinitis, we generally find that there's no effect on their day-to-day function. But if patients suffer from moderate to severe allergic rhinitis, their day-to-day function is usually impaired, and that can include sleep disturbance. So clearly it's important to identify a patient's triggers, whether that be grasses, the animal dander, could be occupational triggers such as chemicals, irritants and fumes. And occupational symptoms usually resolve when the person is away from the workplace. We conduct a physical assessment. We inspect the upper airway for swollen turbinates, transverse nasal crease, which is that pitch you can see there in the diagram of the rubbing with the fingers, that upward rubbing. It's called allergic salute. It's often seen more often in children, and it actually ends up developing a nasal crease. Other things that you may see in a physical assessment are reduced nasal airflow, mouth breathing, dark circles under the eyes indicating sinus congestion or sinus pain. And it's important to take a history of relevant coexistent conditions such as asthma and eczema. Asthma, eczema and hay fever or allergic rhinitis, they're all very, very closely linked. So it's not uncommon at all to find that a patient in your clinic, if they have asthma, would have perhaps had eczema as a baby or a child, and may have hay fever, or any of those three often go in combination. And the link there is to the asthma handbook under clinical issues, allergies, allergic rhinitis, adults and adolescents. Any of those pathways there will deliver you more information. So diagnostic investigations, of course, can be required for some of our patients, and that's more so particularly in moderate to severe allergic rhinitis. And skin prick testing is the gold standard investigation. Skin prick testing is conducted with an allergy specialist or in an allergy clinic, more so these days. We used to do it in general practice, but it's more so done in the allergy clinics. And they use commercially available allergens, placing a drop of each allergen on either the forearm or the back, doing a small skin prick under that allergen of the skin, sometimes on the forearm, sometimes on the back, depending, waiting 15 to 20 minutes, and positive reactions are measured by the wheal size, as you can see in that diagram there of the arm. And antihistamine should be avoided for 3 to 4 days prior to skin prick testing. IgE or RAS blood tests can be performed, but they need to be for specific tests for particular allergens. And some people might prefer the blood test over the skin prick testing or vice versa. Tests that aren't useful food allergy testing, because generally food allergies don't cause rhinitis. FBE and total IgE is not of much use to us clinically. And then kinesiology, reflexology, or hair analysis are unproven at this point in time. It's really important for patients or people to speak to their health professional, their GP, respiratory nurse, allergist. They shouldn't just simply rely on over-the-counter medications or remedies. And the first treatment that we'll look at is the intranasal corticosteroid sprays. These are the most effective treatment for patients with persistent or moderate to severe allergic rhinitis. They reduce inflammation in the lining of the nasal passages. They reduce swelling and reduce mucus production in the nose. Some of these sprays are available without prescription, but stronger versions are available on prescription. These intranasal corticosteroid sprays should be taken regularly, and they also should be taken long-term, like preventer medications for asthma. They don't provide immediate relief of symptoms. In fact, patients won't feel relief for at least 2 weeks after beginning a medication. Therefore, it's really imperative that the patient sticks to their routine and to their dosing regime to gain the maximum benefit from the intranasal corticosteroid sprays. Looking at antihistamine nasal sprays, these are available over the counter. They can provide quick relief of symptoms such as itching and sneezing, and they may help with a blocked nose, and relief is usually within 15 minutes. Antihistamine sprays are not as effective as the intranasal cortico sprays in controlling severe nasal congestion and drip. They don't need to be used regularly to be effective, but rather they can be used as symptoms arise. And they can control symptoms for up to 24 hours. So they're more like our reliever medications in asthma. Then we have combination sprays. So these combine the corticosteroid spray and also the antihistamine. And these are all scripted in Australia. Some of them are, let me think of an example, Demista and Ryaltris, which is a new spray. So these combination sprays give the advantages of both the corticosteroid and the antihistamine. Then looking at the rapid-acting oral antihistamine tablets, these are effective for controlling itching and sneezing, but they're definitely less effective for clearing blocked noses. And if the response to an intranasal corticosteroid alone is inadequate, despite regular daily use and correct spray technique, you would add an intranasal antihistamine and continue the intranasal corticosteroid as well. So combine both. And it's not mentioned here, but decongestant nasal sprays and tablets are used to unblock the nose, but shouldn't be taken for more than a few days at a time, as they can tend to have a rebound effect and cause nasal passages to become inflamed and swollen and congested. Then we have the saline sprays and rinses, which are not the most pleasant procedure, but they can certainly be effective, and they help to flush away the allergens and irritants from the nose and keep the nose clear by thinning and loosening the mucus. And when symptoms improve with any of these treatments, the dosing or the treatment can be reduced. Allergen avoidance is obviously advised once the allergen or allergens have been identified, and immunotherapy or desensitization may be a preferred option for some patients rather than continual medications and sprays. This is the regular administration of commercially available allergen extracts, and they could be administered either sublingually or subcutaneously to promote clinical tolerance, and they can modify allergic immune responses. Avoid oral corticosteroids, and there are allergy treatment plans available, the ASCIA website, which I'll show you shortly, and the NAC has how-to videos which demonstrate and supply information on correct use devices such as nasal sprays, all of our asthma medications, of course, and sinus rinses. One good thing with the how-to videos on the NAC website is, for instance, the correct use to use the intranasal corticosteroid spray, because side effects with these sprays can include blood noses. A lot of patients don't direct their spray away from the nasal septum. The nasal septum is very vascular, and therefore blood noses can occur. So it's important for patients to be educated correctly on all of their devices, whether it be asthma medications or allergic rhinitis medications. So these are a couple of the treatment plans for allergic rhinitis. And the one on the left-hand side is available on the Australian Asthma Handbook website. And the one on the right is the Asthma website treatment plan. So just looking at both of them, looking at the one on the left from the NAC, if a patient has persistent or moderate to severe intermittent allergic rhinitis, we would perhaps start them on an intranasal corticosteroid, plus or minus that antihistamine spray. Consider short-term addition of either an antihistamine spray or a decongestant only for 3 to 5 days. Then you would review in 3 to 4 weeks. If their symptoms are controlled, you would continue the intranasal corticosteroid spray plus or minus that antihistamine, and that would be long-term. After 3 to 4 weeks, if their symptoms are uncontrolled, you'd always review the diagnosis, check their adherence and that they're actually using those sprays as they should be, check the device technique and consider allergy testing. That can then lead on to intranasal antihistamines with the intranasal corticosteroid, and again, controlled or uncontrolled. Hopefully they're controlled by this point, but if they're uncontrolled, we'd refer to an allergy specialist. On the other hand, if they're only mild intermittent sufferers of allergic rhinitis, we would commence them on the oral antihistamine or a montelukast and review in 2 weeks. If that controlled things, you would continue generally just throughout the allergen season. Or if the patient is uncontrolled, their symptoms are uncontrolled, you would then perhaps commence the intranasal corticosteroid. A lot of people do ask me, so I'll just give an explanation of the montelukast. It's neither an antihistamine nor a steroid nor a decongestant. The montelukasts belong to the meds called the leukotriene receptor antagonists, and they work by blocking the action of the leukotrienes in the body, which are responsible for causing inflammation and mucus buildup. And then on the right-hand side is the Asthma allergic treatment plan, quite similar to the one on the left-hand side. It just talks about the different medications and whether to have them once or twice a day. Are they to be used in 1 or 2 nostrils? It's usually both. And it explains whether to use the sprays for 1 week, 2 weeks, or however many months. And also a little note about how to actually use the sprays, priming the device, shaking the bottle, blowing the nose, tilt the head slightly forward, as you can read there, and so on and so on. So they're available on the left-hand side at the NAC Asthma Handbook website, and the one on the right-hand side at www.allergy.org.au. That's the Asthma website. This is our very latest allergic rhinitis treatment chart, and it was only released last week, so I did a rush job this afternoon to try and put this new chart in. It's pretty much the same as what we did have. It's just an extra medication there, Ryaltris there under the antihistamine/corticosteroid group up the top there. And the other addition to this chart is the QR code down on the left-hand bottom corner to our how-to videos, so talking about or educating the patients on how to use those devices there on that chart or on our asthma medication chart. So if we haven't seen a response to treatment trials within 3 to 4 weeks, we may need to refer our patients on. The allergic rhinitis symptoms may be persisting, they may have become more severe, and there's just no response to treatment. Our asthmatic patients may be experiencing persistent or increasing symptoms, and there may be continuing poor asthma control despite regular preventer medication. Other allergic diseases such as eczema may be present. Food or an occupational allergy may be suspected, where symptoms are worse in the workplace, and often spray painters find that they are susceptible to rhinitis. And referral may in fact be to an ENT specialist rather than an allergy specialist for complications such as resistant obstruction, and that can be unilateral or bilateral, sinus disease, anosmia, which is the loss of ability to smell, ear problems, and the worst case scenario be persistent purulent discharge. There could potentially be a polyp that is unresponsive to initial intranasal corticosteroid spray treatment. And as mentioned earlier, referral to an allergy specialist is required if immunotherapy is contemplated. I just thought we'd pause there for some questions, so please feel free to type them into the chat box and Mel will read them out to me if you have some. If not, we'll keep going. I'll definitely have time for questions at the end if you can think of any questions by then, but please, if you do have one, ask away. We'll keep going. All right, let's move on to thunderstorm asthma. And these are a couple of definitions of thunderstorm asthma, and we, of course, are a bit biased and like the second definition, that's from the National Asthma Council, but I'll read both out to you. An observed increase in acute bronchospasm cases following the occurrence of thunderstorm in the local vicinity, or an unusual cluster of allergic asthma flare-ups, including severe acute asthma associated with some types of thunderstorms in spring or early summer. Now, this slide shows a timeline of thunderstorm asthma events in Melbourne over the past 4 decades. And Melbourne's November 2016 event was the largest and most devastating thunderstorm asthma event ever recorded worldwide. Severe thunderstorm activity in Victoria on November the 21st, 2016, led to thousands of people suddenly having asthma attacks and finding it hard to breathe. And emergency departments and emergency facilities were overwhelmed by the volume of asthma sufferers who presented, needing urgent attention at the one time. The majority of those affected in that asthma event were younger people, with the median age being only 32 years of age. So in this table, you'll note that the history of all these events is in the month of November. November is the danger month as ryegrass has matured. And it's also interesting to note the times of the events and the presentations to ED. So you'll see there in November 2011, the time of the event was in the middle of the night or early morning to 6:30. So 3:30 to 6:30 in the morning, where the hospital presentations were only 30, whereas in the November 2016 event, the onset time was 6 o'clock in the evening, and there were over 3,500 presentations to ED, 35 ICU admissions, and tragically 10 people passed away. And Melbourne isn't the only place that has recorded thunderstorm asthma events. There's been other episodes reported in Tamworth back in the early 90s, Wagga, Newcastle, and Canberra more recently. And there's been several incidents that have been recorded internationally as well. So some data from DHHS here in Victoria. In the 30 hours after 6 p.m. on the 21st of November 2016, there were 3,365 excess respiratory-related cases presenting to Melbourne Metro public hospitals. That's a 672% increase above the 3-year average. And 476 excess asthma-related admissions to public hospitals in Melbourne, which is a 992% increase on the expected. As I said, it wasn't just emergency departments, it was ambulances and paramedics, GP clinics, and a lot of pharmacies. A lot of people presented to pharmacies looking for help. And about 2/3 of people who presented to hospital in that 2016 event didn't actually know that they had asthma, but when questioned by the nurses or the doctors, A further half of those people reported previous asthma symptoms, including shortness of breath, cough, wheeze, and nighttime waking with cough or wheeze. So they had in fact experienced asthma symptoms in the past, they just hadn't ever been diagnosed. So for a thunderstorm event to be significant, it needs to be a high pollen day. Perennial ryegrass, a common pasture crop, as we all know, has been implicated in all Australian thunderstorm epidemics. And fungal spore and dust may also contribute to the risk for some people. The Australian Bureau of Meteorology 2016 Victoria map there that you can see down the bottom, that maps from the 1st of September to the 30th of November that year, where the light purple and dark purple represents the higher levels of rainfalls. So the lighter purple represents above average and the darker purple very much above average or highest on record. So this high rainfall in the spring of that year, 2016, enhanced prolific growth of grasses and therefore pollens throughout Victoria, especially in the western half of the state. And having said that, there's been high autumn rainfall this year and predicted high spring rainfall. So we need to just be mindful and be careful. So large pollen particles are normally filtered in our nose, and that's at around 10 micrograms in size. Thunderstorm moisture breaks down these pollen particles to less than 2.5 micrograms, where they are then inhaled into the very small airways in our lungs. And it's not just asthmatics who are at risk, but also those people with allergic rhinitis. Not all spring thunderstorms lead to thunderstorm asthma. It's to do with change in humidity and a drop in pressure. And this slide shows a visual representation of one hypothesis for the mechanism of thunderstorm asthma and how, if it is also a high pollen count day, the thunderstorm can deposit smaller than usual particles in the air and have the potential to cause problems for those with asthma and or allergic rhinitis. Storms may increase allergic reactions by breaking pollen grains into smaller particles that are then more easily breathed in, as I've said. So in this slide, we have the updraft, and that carries whole pollen grains up into the cloud as the storm matures. So the whole grain fragments of about 10 micrograms are lifted up from the grasses in that updraft up into the cloud. The moisture in the cloud then fragments the pollen into smaller pieces. We then have the downdraft, where the dry, cold outflows carry these much smaller pollen fragments to ground level, where people can obviously breathe them into their lungs. So the strong wind gusts that precede a thunderstorm provide a very efficient mechanism for exposing large numbers of people to lots of pollen allergens suddenly and at the same time. Depending on the storm's movement, these gusts may travel over large areas before diminishing, and then large numbers of people therefore are affected by asthma symptoms at similar times during this sort of thunderstorm asthma event, and it is termed epidemic thunderstorm asthma. There's in fact some new research being conducted in the UK. It started in April this year, and they're suggesting that there may be other impacts, such as, well, we know that wind is definitely involved, but they're suggesting that lightning may have some form of means to causing thunderstorm asthma. So we will certainly update any information that's on our websites and on the ASCIA website as new information comes to hand. This is a little video of pollen rupturing. Let me see if I can play it. But often, let's see if it'll play. Oh, good. So this is demonstration of those larger pollen fragments of about 10 micrograms, the normal pollen, being ruptured in the cloud, and you can see how they get ruptured into much, much smaller particles, and that's why they're very easily breathed in during a thunderstorm event. So there's many different categories of people who are at increased risk of thunderstorm asthma. So we'll go through those now. So people with sensitization to ryegrass pollen, they are definitely at increased risk. People with seasonal allergic rhinitis related to grass pollen who have asthma or who have never had asthma. So allergic rhinitis with or without known asthma. People with asthma, especially if they are poorly controlled or not taking preventer medications, they're particularly at risk. Those people that have ever had asthma, for example, someone might have had childhood asthma, and they may still in fact have that hyperresponsiveness in the airways, sometimes referred to as the airways being twitchy or supersensitive due to the very small pollen particles, less than 2.5 micrograms. Their old asthma, if you like, gets triggered. And this risk increases even more in patients with both asthma and allergic rhinitis, or in patients with poor control or who have been previously admitted to hospital or particularly into an ICU. And then, of course, there are those people with undiagnosed asthma or poor perceivers of their asthma. Another group of people are those who are exposed to open air before and during a thunderstorm in pollen season. They're in a high-risk category for developing thunderstorm asthma. And finally, people living in areas prone to high pollen, of course, are obviously at risk as well. And evidence from the November 2016 event suggests that the higher risk is in the southeastern Australia populations. So it's very important, clearly, for us health professionals to be aware of where the areas are that are more prone. In fact, when we discuss areas now in our webinars or our workshops, we discuss from Tamworth in New South Wales, obviously, down, right down to the lower parts of Victoria as the increased risk zones. Just going to have a sip of water, excuse me. So one of the big risks regarding thunderstorm asthma is that for many people it's completely unexpected. So they may not have awareness of or access to reliever medication or an action plan to keep themselves safe. So general advice, not medical advice, but general advice for all of those categories of people who are at risk are to avoid outdoor exposure when the pollen count is high and thunderstorms are predicted. And you can either watch the daily news broadcasts or the weather reports, often at this time of year, that tell us about pollen count. There's also apps there, such as the Australian Pollen app in your state or territory. We have the Melbourne pollen count here, the Air Rater app, and the emergency websites. It'll be Vic Emergency or New South Wales Emergency website. They can always tell us every day what the pollen count is going to be. Inside our houses or our cars, we would close windows, we would turn off air conditioning, or use recirculated air on those high pollen days or predicted thunderstorm event days. If there's any signs of asthma, we would always provide a written action plan and suggest to the person or the patient that they have a written asthma action plan or allergic rhinitis treatment plan. Or if there's no plan, then follow asthma first aid steps, which is the 4x4x4, which we will go through shortly. And if asthma symptoms were to worsen rapidly, we would always be calling 000. Medical management for those with asthma and allergic rhinitis. Well, we always want to be proactive leading up to spring. We don't want to wait for something to happen. We would like the patients to arrange a review appointment. We can use telehealth, and we would discuss the increased asthma risk. We would ensure correct diagnosis of asthma and or allergic rhinitis. We would expect the patient to know and understand and manage their triggers. We would address both lifestyle and medical management of asthma and allergic rhinitis. They should be taking prescribed medications. They should understand reliever therapy, and we need to ensure correct device technique. I can't say often enough how correct device technique and checking that technique is so important. It can be the smallest of things, such as misuse of a device, that can make all the difference. And we would always suggest and advise where to look, such as those websites and apps for high pollen days or thunderstorm events. Other medical management would be to manage and regularly review patients with asthma following the current guidelines from the Australian Asthma Handbook. Only very few people should be managed with reliever medications alone. Only those people who experience symptoms less than twice a month should be only on relievers, only less than twice per month. Anyone who experiences symptoms more than 2 times a month should be on preventer therapy. So most people nowadays with asthma should be on preventer therapy. And Symbicort or budesonide formoterol should be indicated, or is indicated, I should say, for mild asthma. So if an adult or child who has asthma and or allergic rhinitis is not already on inhaled corticosteroids or intranasal corticosteroids, they should be commenced ideally 6 weeks, but at least 2 weeks before the pollen season, and they should be maintained on those medications until December. So preferably 6 weeks, and that is one of the reasons why it's so good that you're online tonight learning about this, because you've got plenty of time to prepare your patients. Oh, sorry, accidentally moved forward. Patients should always carry their reliever, even if they're on preventers. As I said, most patients with mild asthma should now be on preventer medication, but they should always carry their reliever with them, either Ventolin or Symbicort, depending on the option that their GP has discussed with them for their reliever medication. And they need to make sure that they replace their medication before it's expired or when it's nearly empty. So many patients wait until their medication is empty or until it's expired, if they even check that it's expired, before they make their appointment to go and get their script from the doctor. And then 2 or 3 days without preventer medication can be enough for them to be symptomatic. A review for allergic rhinitis is important, and treated if present. Again, commence the intranasal corticosteroids at least 2 weeks, if not 6 weeks before the season commences, and the written action plans or allergy plans. And that could include thunderstorm advice and instructs the patient to increase doses of both inhaled preventer and reliever, as well as response to flare-ups. We should also warn our patients against being outdoors just before and after thunderstorms, especially in wind gusts that can precede the rain front. So for those people with allergic rhinitis but no asthma, pretty much the same medical advice, but these individuals are at risk if they live in a region or travel to high pollen areas, including those who have never experienced asthma before. So we would manage their allergic rhinitis as per the current guidelines. Then for those with allergies to grass pollens, again, treat with the the intranasal corticosteroids, 2 to 6 weeks. We've got 4 weeks there. We've just gone the average, but 2 to 6 weeks before and throughout pollen season. There is insufficient evidence to prove that the intranasal sprays protect against thunderstorm asthma, but evidence definitely exists that the lack of inhaled corticosteroid preventer is a risk for thunderstorm asthma. So we want to educate on the risks of thunderstorm asthma for those people with allergic rhinitis, and they would be able to access their reliever medications over the counter, unless they already receive a scripted anti-inflammatory reliever purely for the allergy season to use as needed. And that is certainly common. A lot of patients are only on preventer medications from, let's say, April through to October, because they have the allergic rhinitis and the atopic component of asthma. And we would want to explain how to recognise asthma symptoms and what to do, know how to get a reliever and how to use it. Again, ensure correct device technique and provide asthma first aid information. And for those people who are lucky to not have asthma or seasonal allergic rhinitis, we want to reassure these people that their risk of thunderstorm asthma is low, but we do want to raise their awareness of asthma first aid. The more people that can assist with asthma first aid in the community, the better, and the more lives will potentially be saved in an emergency event like that one in November 2016 here in Melbourne. Just a little bit on the written asthma action plans. These are more than just a paper. They offer life-saving advice. It is literally life-saving advice. And severe or life-threatening asthma attacks are more likely to occur in patients with inadequate medical supervision. An individualised written asthma action plan should be developed so that a person with asthma can recognise deterioration of symptoms and respond appropriately. And they really do improve outcomes by improving asthma control. Written action plans enable our patients or their carers to recognise worsening asthma. And worsening asthma may be an increase in symptoms such as wheeze, cough, breathlessness, especially waking from sleep, changes in exercise tolerance. It may mean an increased use of reliever medication, or it may mean falling or variable peak flow readings. So the written asthma plans instruct the patient or carer how to respond appropriately. They give advice for adjusting medications, advise when to see your doctor, and when to call an ambulance. Written asthma action plans must be personalised. Obvious, I know. They must be in language that the patient understands, and a useful resource is the Asthma Handbook. They come in a variety of forms, written asthma action plans. They actually come in flip books now, and they come in 12 different languages in audio tapes. And they also are available on each format of practice software, such as Best Practice, Medical Director, and pharmaceutical companies release their own action plans as well. The NAC have their own written asthma action plan, and the Royal Children's Hospital also have a version. So there's plenty around for each and every person. The most action plans, I just like to point out, are colour-coded. Green for when feeling well, orange when symptoms are increasing, and red when asthma is more acute and patients need to actively seek advice. This is the pharmacy or community first aid protocol, also known as the 4x4x4. I'm sure all of you have seen this. And this is useful for, as I said, the community, so for sporting clubs, schools, pharmacies, and everyone out there in the community. And this is currently being updated. So we'll have a new chart with a little less writing. So first step, give 4 separate puffs of SABA, usually a Ventolin, via a spacer. The patient needs to take 4 breaths per puff. We then wait 4 minutes, and if symptoms persist, repeat steps 1 to 3. So 4 separate puffs, 4 breaths per puff, waiting 4 minutes, and then repeating if symptoms persist. If there's still no improvement, call an ambulance and continue the 4x4x4 until help arrives. And of course, we would always stay with the person. We would sit them up, calm them and reassure them, because of course, I don't know if any of you have had the unfortunate feeling of feeling very short of breath, or in fact, you might have asthma and know what it's like to have an asthma exacerbation. It is so scary, and naturally you become anxious when you can't breathe properly. And anxiety, of course, and stress just exacerbates the tightening of the airways. So it's really important to try and calm them and reassure them as best you can. And we are usually administering the medication for them. So these charts are available on the NAC website as PDFs, and as I said, these are currently being updated. So I think they're going to be released in August. So have a look on the website for new versions, and we can send some out to you if you like. So how to prepare for springtime thunderstorm asthma season. At your clinic, prepare early. Proactively review those patients with asthma, especially those with a history of springtime asthma and/or allergies and/or previous thunderstorm asthma. Complete a database search and take the chance to have a telehealth consultation to review your patients. Be aware of high pollen and thunderstorm weather forecasts. Ensure that you have your short-acting beta agonists such as Ventolin and Bricanol in your clinic. Make sure they're in date and make sure you have an adequate supply. And that was one of the major problems here in Melbourne. In the November 2016 event, we ran out of Ventolin and we ran out of spacers. At your clinic, have a supply of spacers. And a possibility, I shouldn't ever recommend a particular spacer one over the other, but light airs are a cardboard, small rectangular spacer. And these are very useful to store in clinics where you may have limited space. They're collapsible and really easy to store, so contact your medical suppliers for those. Sorry. Have a clinic policy for patients presenting with asthma exacerbation. All staff, including medical receptionists, practice nurses and GPs, should be all aware of their responsibilities. Train all staff in asthma first aid and have charts on display. Perhaps have patient brochures in your waiting areas, posters in the toilets even. Put an article in your monthly newsletter or on your website and really promote awareness. And that coach program listed down the bottom there is with Asthma Australia. It's a confidential free health service delivered over the phone by Asthma Australian coaches. The program helps people with asthma to provide education in order to care for someone with asthma really and improve their general health and asthma control. Just going to have another sip of water. Excuse me. At your pharmacy. So particularly in that November 2016 event, many people presented to pharmacies for medical assistance. So pharmacies need to ensure there's an adequate supply of asthma medications. Again, maintain an adequate supply of spacers. Have a pharmacy policy for patients presenting with an asthma flare-up, and they could certainly use our flow charts available from the NAC. All staff, including pharmacy assistants, the dispensing technicians and pharmacists, they all need to know their responsibilities and prioritise these patients if an event should occur. Train all staff in asthma first aid and have charts on display. And pharmacies should always know which GP clinics are open and be able to assist if appropriate. For patients requesting hay fever medications, either the intranasal corticosteroid sprays or antihistamines, pharmacists should always ask about asthma symptoms. They should recommend GP reviews if asthma symptoms are identified, ask them if they've had previous thunderstorm asthma episodes and if they've been symptomatic through any thunderstorm asthma events or thunderstorm events, and if so, they might be at risk and should be reviewed by their GP. So thoughts to consider for your clinic or your workplace or your healthcare facility is, does your workplace have an emergency asthma plan policy? Who has responsibility for different aspects of care? Is there a consistent approach to emergency asthma management? Does everyone in the practice know where the reliever medications are kept and also where the spacers are kept? And they can refer to the asthma handbook for hints and tips on setting up your clinic or workplace. Just a little bit on asthma and COVID-19, referring to the Australian Asthma Handbook again. We've written spirometry infection guidelines, and I've regularly updated those and looked again according to the TSANZ guidelines. So TSANZ is the Thoracic Society of Australia and New Zealand. Their guidelines are always being updated, and we therefore update our guidelines according to theirs. There's been no need to update or make any updates since January, which is good. However, we always do suggest, depending on your state or territory or region, as to where you're sitting with COVID, so look up the recommendations as to what you should be doing with regards to spirometry. We should be checking that everyone with asthma during these COVID times has a current written asthma plan. We advise to continue with current medications, including their inhaled corticosteroids. Only use oral steroids for severe flare-ups as indicated. Avoid using a nebulizer. A well-fitting mask and spacer with puffer is preferred. That goes without saying at any time. A puffer and spacer is always preferred, but particularly during COVID, of course, because the aerosols generated from the nebulizer can potentially spread the virus. We would advise patients not to share medications or spaces even between family members. And we would always plan how to prepare for a scenario of an emergency asthma event during COVID. That includes infection control issues, social distancing issues, PPE, reliever and spacer use, your clean down and disposal of treatment spaces and meds after the patient has been to you and has perhaps been transferred to an emergency department or a hospital. So all these things need to be prepared and learnt before the actual event. So we're getting towards the end. This is just a list of our resources here. You've heard me talk about the Australian Asthma Handbook plenty of times. And different resources available at the NAC website are written asthma action plans, medication charts, the rhinitis medication charts that I showed earlier, the first aid charts, thunderstorm asthma information papers, thunderstorm asthma for pharmacist papers, managing allergic rhinitis in people with asthma, that's a good paper, intranasal spray techniques, and as I mentioned, the how-to device videos, they're becoming more and more popular and very easy for patients to log into and have a look at, and spirometry infection control recommendations. We've also listed for you there Asthma Australia's website, and that's the number for the coach program, and the ASCIA website for allergies as well. This is just the acknowledgements page for those of us who are in the expert review group for this webinar. And I just want to thank you all for attending this evening's webinar. This is a QR code. Hopefully you've all been able to grab your device or had it sitting near you, as Mel suggested at the start. You can actually scan this QR code now if you like, and that will take you directly to the evaluation survey. Mel's going to be sending out the link also, but we've decided to pop these QR codes in recently just as an easy way for you to fill in that survey for us. Our funding from the government at the NAC depends on your evaluations. It's so important that we receive your feedback. It enables us to tailor our sessions according to your needs and your wants. If you want more information included, less information, more pictures, more videos, please feel free to tell us good and bad of what you think of each of our webinars and our workshops when we start to present those to you in a couple of weeks, which we're very excited about. I might just leave that up on screen for a moment, Mel, just for people to have the chance to scan that. And
Sure.
I'll ask you any questions.
Yeah, there's a couple of questions that have come through. What are some of the nasal sprays that we can write a script out for, and will this make treatment cheaper for patients?
Well, Ryaltris is a new one, as I mentioned. That's the new fancy medication. So Ryaltris is a good one. The good thing is that a lot of them, well, not a lot of them, 2 or 3 of them that once needed a script are available over the counter now. So Nasonex is one that's available over the counter, which is very, very handy. It also used to cost a fortune. It used to be $50 or $60, I remember, back when I first started with respiratory clinics. But now they're around $20, so that's really handy. I'll just get my chart up and have a look, but I definitely know Ryaltris is on script. It just came onto the PBS a couple of months ago. The Demista, I think you might be able to get that over the counter as well, but certainly the corticosteroids would be available over the counter. I know Avamis is. If you're lucky enough to have drug reps come around, they often drop off Avamis, Nasonex and Rhinocort. They're all available, but yeah, the Demista and the Ryaltris I think would be the 2 that you would write the scripts for. they're a bit stronger. So we need scripts for those ones.
Okay, great. And this one's very similar. Nasal sprays are on scripts for patients, so I think you've kind of covered that. Now you're going to have to help me with the name of this medication. Is it Montelukast?
Montelukast,
Yeah. Indicated for allergic rhinitis only, or do you need a diagnosis of asthma with allergic rhinitis to initiate it?
As far as I'm aware, you only need to be diagnosed with allergic rhinitis. Montelukast is not used as commonly with asthma these days. It used to be in the form of Singulair for children with asthma, but yeah, definitely not as common. But yeah, no, it is definitely, well, I shouldn't say definitely, but as far as I know, I can definitely follow up and get back to you, Mel, and you can email an answer. But as far as I know, Montelukast is available if a patient only is diagnosed with allergic rhinitis.
Great, thank you. And I'll just wait a couple of more seconds. If anyone else has any questions, could you please enter them in the question box now? We'll just give you a couple of minutes. And while you're looking at that, I'll just remind anyone that's requiring RACGP points and hasn't submitted their RACGP or APRAM numbers, if you could forward them to me via email, that would be wonderful. And this will be on our website for 1 week only, so happy for you to get up there and look. It seems like you've covered everything, Narelle. There's nothing else coming through. If anyone has any questions after the event, they can email yourself or myself, and I'll also pass them on. I do have another one now. The asthma action plan, how can we prepare for it the first time?
How to prepare to get one? Does that question mean, Mel? Or
I think so. Yeah. How can we prepare for it?
Well, as I said, there's plenty around. There should be, depending on what the practices use as far as medical director or Praxsoft, there's always action plans there. As I said, there's action plans available on the NAC website. There's Symbicort specific action plans written by AstraZeneca. There's also GSK action plans. So there's plenty around. So it's just a matter of really just Googling. If you Google asthma action plans, you'll be given a plethora of different options. So again, being biased, I like the NAC one because it is colour coded for when a patient is feeling well or those symptoms are increasing. But yeah, there's plenty around.
Great, thank you so much. And that seems to be all of the questions. So I want to say a big thank you to you, Narelle, for being here tonight and presenting. It's really timely and everyone's got time to prepare for spring. And thank you so much for your presentation tonight. It's been lovely working with you. It's really enjoyed the session. And thank you everyone else for attending this evening. I hope everyone stays safe and well. And we'll see you at our next event. Thanks, Narelle.
Thanks, Mel. Stay safe, everyone. Bye.
Good night.